honor of introducing Dr. Marta Alhama-Belotto today. She completed her medical education and residency in Madrid, Spain, before moving to Scripps Clinic in sunny La Jolla for her fellowship. Her background is in research on medication titration heart failure patients and advanced echocardiographic techniques. She joined us after a fellowship in 2019 as faculty at the University of Washington and spends her inpatient time at Harborview and an outpatient clinic at Salt Lake Union, seeing a mixture of general cardiology and cardio-oncology patients from the Cell Cancer Care Alliance. It has been wonderful collaborating with her because she has boundless enthusiasm for our cardio-oncology program. Whenever a patient needs to be seen or we have any questions, we often will go to Marta and to share complex patient decision-making, such as how best to manage breast cancer patients with cardiotoxicity while balancing their cancer treatments with mitigating worsening cardiac function. She'll be presenting today on this complex topic of cardiac dysfunction in breast cancer patients, monitoring, diagnosis, and treatments.
All right, thank you very much, Richard, for that kind introduction, and thank you everybody for joining me today to talk about this topic. So as Richard said, I joined UW in 2019, and at that time I had the opportunity to be involved in the cardio-oncology program. We still are emerging subspecialty within general cardiology, and many of you continue to see cancer patients in their regular clinics. So I thought reviewing this topic could be helpful for all of you. And I'm going to be focusing on the breast cancer population because it's one of the most frequent patients that we see in the cardio-oncology clinic, and also because most of the data that we have is in this patient population. All right, so I have nothing to disclose. So in today's talk, I'm going to be discussing very briefly the different breast cancer therapies and the risk of heart failure. We're going to be talking about what patients are at higher risk of suffering cardiovascular complications during their cancer treatment, what preventive strategies we have, how we monitor these patients, the role of biomarkers and echocardiography, and especially I will focus on the use of global longitudinal strain. And then finally, we'll talk about what to do with patients who develop LV dysfunction related to their cancer treatment, and how does that impact their cancer treatment. So in the last few years, there's been a revolution in the way cancer is treated, and this has led to a growing number of cancer survivors, either patients that survive their cancer or patients that actually live with their cancer as a chronic stable disease. So in 2016, data from the National Society of Cancer and National Cancer Institute showed that about 15.5 million Americans had cancer and they were alive and living with their cancer. About half of them were women, and most of these women have breast cancer. It's by far the most prevalent cancer in the women population, with 3.5 million women suffering breast cancer as of 2016. So with a growing population of survivors of cancer, the long-term effects of treatment become very important. And we know that in patients that are diagnosed with cancer at young ages, the probability of dying from their cancer is the highest among other causes of death. But as they get older, especially as they get older than 66 years old, when they are diagnosed with cancer, other diseases such as cardiovascular disease become more prevalent, as you can see here in red. Once they develop cardiovascular disease, 4 or 5 years after their cancer diagnosis, actually the probability of dying from their cancer is much less than dying from cardiovascular disease. And this is not only related with the growing cancer population and the increase in age of these patients, they also share many cardiovascular risk factors, such as diabetes, smoking, obesity, sedentary life, but also the effects of these cancer treatments on the cardiovascular system. Since its early recognition, cardiotoxicity with anthracyclines in the 60s and 70s, many other therapies have emerged that have cardiac effects. In the 90s, the HER2 therapy agents became available. And also there was more extensive use of radiation and bone marrow transplant. And nowadays, the armamentarium to fight cancer has increased significantly with an increased risk of cardiovascular disease. Many of these agents have a direct toxic effect on the myocardium, but many others also share molecular pathways that increases the risk of myocardial injury. So cancer treatment can basically affect any element within the cardiovascular system. Patients may develop more frequently hypertension, ischemic heart disease, valvular and pericardial disease. They are more prone to develop arrhythmias, but the most frequent and serious complication of cancer therapies is actually LV dysfunction and heart failure, especially if it occurs during their cancer treatment, because it impacts the capacity we have to fight that cancer. And this is where it lays the stem of the breast cancer therapy, because it basically resides in the use of anthracyclines and HER2 therapies. This is just very briefly the main regimens we have available for the systemic treatment of early stage breast cancer. As you can see, all these regimens are based on the use of different agents. Some of them use anthracyclines, some of them don't use anthracyclines. They use alkylated agents like cyclophosphamide or microtubule inhibitors like the taxols or antimetabolites like 5-FU. And then depending on the expression of some receptors, they may use also targeted therapies like the HER2 inhibitors with trastuzumab, pertuzumab, or both. And the choice of one agent over another is going to depend on many things. It will depend on the cancer characteristic, what receptors the cancer express, the stage of the cancer, some genetic tests that the oncologist will perform, as well as clinical factors like the patient performance status and their comorbidities. So let's start with anthracycline-induced cardiotoxicity. Anthracyclines actually were developed as antibiotics, but were never used as such because they had very significant cytotoxic effects. However, they are one of the most effective anti-cancer drugs that we have, and is still used frequently in patients with lymphomas, leukemias, sarcomas, and of course, breast cancer. So here in your right, you have the effects of anthracyclines in a myocardial cell. Here in the top, you have a normal myocyte. In the middle, you have a cell that have already some signs of anthracycline cardiotoxicity and with vacuole formation. And then in the bottom, you can see the late stages of anthracycline toxicity with myocardial necrosis and cell death. There are several mechanisms by which anthracyclines can cause cardiotoxicity. It causes direct oxidative stress by production of free radicals. Anthracyclines also bind to topoisomerase 2, which is an enzyme that is needed for DNA transcription, replication, and recombination. So when it binds to topoisomerase 2, it will induce apoptosis through mitochondrial dysfunction, cell dysfunction, and the production of reactive oxygen species. We recently learned that also is important alterations in these MDR proteins, these membrane transport systems in the cells, where basically increase the intracellular concentration of these chemotherapy agents and potentially increase the risk of toxicity. So there are some polymorphisms in these MDRs that make patients more prone to develop cardiotoxicity. And also in some patients, some medications used for other purposes, for example, calcium channel blockers can affect the MDRs, increasing the concentration of the chemotherapies in the cells. And then most recently, we realized that anthracyclines also decrease the population of mesenchymal and circulating progenitor cells. And this is one of the theories why some people will develop late onset heart failure, especially childhood cancer survivors. And it has laid the foundation to investigate cell therapy to treat or ameliorate the effects of anthracyclines in the heart. So with this idea, we recently had the results of the Seneca trial, phase 1 trial that investigated the safety of allogeneic mesenchymal cells that were injected into patients who have been treated with anthracyclines and who had ejection fraction below 45%. And the results are preliminary. They show that it was a safe strategy. And although it wasn't powered for that, there was a tendency to increase ejection fraction in these patients treated with mesenchymal cells. They also saw decrease in the scar burden assessed by cardiac MRI, better quality of life, and improvement in the 6-minute walk test. And the theory is that these cells work by mitochondrial transfer. And with this, the cells treated have less apoptosis, increased ATP production, and less oxidative stress. So very exciting field. Now we've learned throughout the years that the risk of cardiotoxicity with anthracyclines depends on the cumulative dose that a patient receives throughout their life. So in the past, we thought that this cumulative dose that precipitates heart failure was actually much higher than what we know nowadays. And now we consider doses of about 240 milligrams per meter square to be high risk for patients to develop heart failure. If you see doses lower than that, have a very flat curve with very low risk of heart failure. But as we increase the dose, the relationship becomes nonlinear and the heart failure risk is significantly higher. However, we've also learned through biopsies of patients subjected to lower doses of anthracycline that there is actually no safe dose. Even with doses as low as 100 milligrams per meter square, we still see some subclinical damage. And actually, there are heart failure cases reported in patients who receive as low as 100 milligrams per meter square of cumulative dose of anthracycline. So there is still some individual susceptibility that probably has to do with genetic variants that hopefully in the future we can start to test. Now, let's change now to the HER2 targeted therapies. So these therapies were developed in the 90s. They are antibodies that inhibit the HER2 receptor or the HER2 receptor. And this receptor is very critical in some intracellular signaling pathways that help with preservation and survival of cells. The way that the HER2 inhibitors provoke cardiotoxicity is not as well known as with anthracyclines, but we believe is through the inhibition of these intracellular signaling pathways, how they impair myocardial response to stress. It also regulates vasomotor tone and sympathetic output. And we've seen in patients with breast cancer treated with these agents that they have increased norepinephrine concentrations. They tend to have higher blood pressure and higher heart rates. And potentially, this is one of the reasons why beta blockers can play a role in the prevention of cardiotoxicity in patients who are receiving these therapies. So in general, 20 to 30% of the breast cancers are going to express HER2 receptors. We know that those cancers in general have much less response to classic chemotherapy. They are more aggressive. They tend to recur more often and patients have less survival. So when these therapies became available, all of a sudden, there were a huge population of breast cancer patients that could be able to survive their cancer. They improve survival in both metastatic cancer as well as early stage cancer by 30%. And in early stage breast cancer, they decrease the risk of recurrence by 50%. But it was also recognized very early in the first trials with trastuzumab that the risk of cardiac dysfunction was quite high, up to 27%, and most of these patients were symptomatic. Despite a very significant cardiac risk, the improvement in survival in the breast cancer population was so significant that the cardiac risk was widely accepted. And then later on, they realized that these increased numbers were actually related with the co-administration with anthracyclines. So nowadays they are administered sequentially. They do the anthracycline first, and then they do the HER2 inhibitors in order to decrease the cardiovascular risk. So let's talk about how we define cancer treatment-related cardiac dysfunction. As you can see, there are many different criteria depending on the society. They share some things in common. We tend to use the ones from the American Society of Echocardiography, where we define cardiotoxicity as a decline in 10 points in ejection fraction for baseline to a level that is lower than the normal limit of normal, 53%, or a relative reduction in global longitudinal strain of at least 15% from baseline. And the ASE actually recommend that when we detect this, we repeat the echocardiogram in about 3 weeks to confirm these changes are actually real. They also mentioned that if you have a relative reduction in GLS of less than 8%, the changes that you are seeing are probably not clinically relevant. So based on this definition, how often we see that? As we said before, with anthracycline, it's going to depend on the dose. For breast cancer, most of the times patients are going to remain on regimens below 240 milligrams per meter square. And the rates of cardiac dysfunction is about 2 to 5%. For HER2 therapies, it's about 5 to 15%. Now, in the past, with anthracyclines, we thought there were kind of three forms of cardiotoxicity: an acute form where you see heart failure within 2 weeks of administration of the first dose of anthracycline, and there was a chronic stage with early onset, that diagnosed within 1 year of the anthracycline administration, and a chronic state late onset when it was diagnosed more than 1 year and many times several years after the administration of anthracyclines. Now, this classification has been challenged recently because it's based on data from the 80s, mainly done in retrospective studies looking only at heart failure symptoms. They were not looking at ejection fraction, and mainly in childhood cancer survivors. So it's possible that what they were seeing were the late effects of, a disease that started earlier, right after the chemotherapy administration, and that has been unrecognized. So there are very nice studies done in the adult population in the last few years. This chart up here comes from one of the largest one in 2,700 patients treated with anthracyclines, half of them breast cancer patients, where they try to define the timeline of occurrence of heart failure. What they saw is about 9% of patients will develop cardiotoxicity, and 98% will develop cardiotoxicity within 1 year of receiving anthracycline. And the median time between the anthracycline administration and the recognition of LV dysfunction was about 3 months. This actually is quite important, right? Because we cannot offer long-term surveillance to all patients with a growing cancer patient population. It wouldn't be logistically and economically feasible. So if we focus our efforts in that first year after anthracycline treatment, we're probably going to catch most of them. The other thing that they realized is that in this first year, most of the patients were asymptomatic or with very minimum symptoms. And as you wait longer, the patients have more refractory heart failure, overt heart failure, probably are reflecting more significant and irreversible myocardial damage. Now, with HER2 treatment, we've tried to look what are the risk factors that predispose these patients to cardiotoxicity, and we've seen that the strongest risk factor is actually anthracycline administration, also older age when they received HER2 therapy, and the ejection fraction right before they received trastuzumab. What we've seen in these patients is that thankfully for the HER2 therapies, when you stop the treatment within 4 to 6 weeks, they tend to have improvement in their ejection fraction. So let's look at the timeline, how we treat these patients. They are going to start their cancer treatment. Some of them will develop myocardial damage and then eventually LV dysfunction. And we are trying to catch the patients early here in the development of the disease before they are going to develop heart failure symptoms. So hopefully we can catch these in a still reversible state. So why don't we start by first recognizing what patients are at higher risk of developing that so we can focus our attention on them. And we know that there are risk factors related to the patient and risk factors related to the treatment they are going to receive. So these are the main risk factors according to the American Society of Clinical Oncology. In terms of the patient-related risk factors, having 2 or more classic cardiovascular risk factor increases the risk of cardiotoxicity. Patients older than 60 years old when they are receiving their cancer treatment and having pre-existing cardiac disease, meaning heart failure, decreased ejection fraction, previous history of myocardial infarction. As you can see, we are not narrowing the spectrum of the patients too much because, as we said before, these patients share many cardiovascular risk factors. And then looking at treatment-related risk factors, as we said before, high-dose anthracyclines, high-dose radiation, but also low-dose anthracycline when they also are going to receive low-dose radiation when the heart is in the treatment field, or low-dose anthracycline followed by HER2 inhibitors. And then there is a group of patients who develop cardiotoxicity who don't have any of these risk factors that in theory would be low risk, but they still develop cardiotoxicity. So there is still probably some genetic susceptibility that we still don't know how to test or identify appropriately. There are many scores that have been developed to stratify these patients. This is one of the most comprehensive ones from the European Society of Cardiology, where they stratify patients into low risk, medium risk, and high risk, and they consider the variables that we just mentioned. And they also recently developed these assessment tools for many different cancer therapies where you can stratify your patients based on all these variables. What happens with these assessment tools and risk scores is that they have not been validated in prospective studies, and we also don't know how we should manage and monitor different patients that are low risk versus high risk. But one could argue that probably those patients with low risk don't benefit that much from very close monitoring, or at least it's very unlikely that we are going to make management changes based on that monitoring. So still more studies needed in this field. Now, another strategy that is very promising is primary prevention of cardiotoxicity. Why don't we start these patients on medications to prevent cardiotoxicity? And there are many agents that have been looked at, ACE inhibitors, beta blockers. They both seem to decrease the oxidative stress. ACE inhibitors also can modulate the HER2 receptor. There's been some work with statins. They decrease oxidative stress, but they also can modulate topoisomerase 2. There are no randomized controlled trials with statins. There are some ongoing, but no results yet. But there are some retrospective studies showing that patients on statins during chemotherapy have less heart failure. And then we also have Dexrazoxane up here, which is an iron chelating agent. It decreases oxidative stress, but also modulates topoisomerase 2. So let me just review the evidence behind that agent. The studies are very heterogeneous. This is a recent meta-analysis that included 2,100 breast cancer patients treated with anthracyclines, and they saw that when they were treated with Dexrazoxane, there was a decrease in heart failure from about 9% to 1%, and a decrease in cardiac events from 15% to about 5%. So it seems that it works well. However, there is some conflicting data that this agent can decrease the anti-cancer effects of the chemotherapies and can also promote second malignancies. This meta-analysis didn't show a signal there, and the oncologic response and the overall survival was not changed by the use of Dexrazoxane. However, they saw that most of these trials have very significant risk of bias, especially selection, performance, and detection bias, and there was incomplete outcome data in most of them. So it's just a proof in patients who have metastatic or advanced breast cancer when they have reached a cumulative anthracycline dose of 300 milligrams per meter square, and they have to continue anthracyclines because it's their best option. So it's a reasonable alternative when they don't have any other cancer therapy available. In terms of heart failure therapies for primary prevention, also the studies have mixed results. As you can see, the numbers in the studies are not very high. These are all breast cancer patients, or mostly breast cancer patients. They use different strategies, different primary outcomes, and also different ways to define cardiotoxicity. And this is part of the limitations of these studies. Also, for example, here in the PRADA study, they actually saw a significant change in ejection fraction by the use of candesartan, but is questionable if these small changes are actually clinically relevant. Beta blockers showed some promising results in early trials, but this actually was not shown in the studies like PRADA, for example, with no effect of beta blockers, or the SAFE-HERT trial, specifically looking at carvedilol. In this trial, the results were very discouraging. There was no difference between placebo and carvedilol, but the follow-up was actually very short, it was only 6 months. They did see that these patients on carvedilol have lower troponin elevations and less diastolic dysfunction, so potentially there may be some benefit in the long-term risk of developing cardiac dysfunction, but this is still not known. Now, in one of the largest studies, this one down here, the Gaglin SCAP study, they didn't see any difference in terms of ejection fraction decline with the use of carvedilol or lisinopril. However, they did see there was less cardiac dysfunction related with cancer treatment when they looked only at the patients that received both anthracycline and HER2 therapies. So probably better study design, hopefully with longer follow-up, looking at this especially high-risk patients may throw some light in the use of these primary prevention strategies. Nowadays, with this data, the only thing we can do is that if you have a reason to start beta blockers or ACE inhibitors, for example, if the patient has hypertension, I'm going to favor those agents as opposed to calcium channel blockers. All right, so we have identified what patient potentially is at risk. We've treated their cardiovascular risk factors, optimized their cardiovascular disease, if there is one. Now let's follow them during their cancer treatment. We are going to try to catch and diagnose LV dysfunction as soon as it occurs. We can just wait for LV dysfunction to show in the echocardiogram. This may take weeks or months. Or we can just look at early stages, just myocardial damage with biomarkers. So let's review the biomarkers first. So this is a very nice study done in breast cancer patients. I put here the study design because it shows one of the most frequent protocols for breast cancer therapy and how long it takes for these patients to complete their therapies. They start with anthracyclines that are administered every 3 weeks. During for about 4 cycles, and then they switch to trastuzumab that is given every 3 weeks also to complete 12 months, and they receive paclitaxel every week for about 3 months. So these patients were seen every 3 months with echocardiograms, biomarkers, and questionnaires, and what they saw is that the peak troponin happened 3 months after they started anthracycline. And this peak troponin was associated with the risk of developing heart failure later on. An abnormal troponin in this study, troponin I above 30, together with an abnormal longitudinal strain, had a sensitivity to detect cardiotoxicity of about 87%, with a negative predictive value of 91%. And what they saw in this study is that NT-proBNP didn't offer any advantage and was not even associated with the development of LV dysfunction later on. This other study tried to show, okay, so troponin is associated with high risk when we should monitor troponin. So they looked at early troponin within 3 days of chemotherapy and late troponin at 1 month of chemotherapy. And what they saw is that patients may increase troponin early on after chemotherapy, but many patients didn't have late troponin despite having an abnormal troponin initially, and some other patients will have increased late troponin. And there were these patients with increased late troponin here in black, the ones that have a higher risk of developing LV dysfunction. And not surprisingly, these are the ones that have the most complicated course and the most frequent cardiac events. Now, looking at BNPs and NT-proBNPs, the data is less robust. In this study, they look at patients that didn't receive high-dose chemotherapy, and they divided them into those who have normal or transiently elevated NT-proBNP with the dashed line, and solid line are patients who have persistently elevated NT-proBNP. So the ones that have a persistently elevated NT-proBNP are the ones that are going to have a decline in ejection fraction later on when they complete their treatment. However, this has not seen in other studies. This one right here that looked at many different biomarkers didn't show any association with LV dysfunction, as opposed to, for example, troponin I. So what we can conclude for biomarkers to predict cardiotoxicity is that time is key. The utility of troponin in predicting ejection fraction changes is going to depend on when you check the troponin. So most patients are going to elevate troponin early after chemotherapy, and troponin elevation within the month is associated with a higher risk of LV dysfunction and heart failure. A negative troponin within the month is associated with no significant ejection fraction reduction. Transient BNP changes doesn't seem to be predictive of clinical outcomes, but persistent elevation of BNP is, and maybe there is a role here for long-term follow-up of these patients. Now, I didn't show any data because there is no really any data to support changes in cancer treatment in response to elevated cardiac markers. So we shouldn't modify the cancer treatment because they elevate troponin, but those are the patients we need to follow very carefully, monitoring it more often, probably doing more echocardiograms, and we should consider cardioprotective therapy in these patients. Now let's talk about imaging. So remember, we said we defined cancer treatment-related cardiac dysfunction as a change in ejection fraction of 10 points to a level lower than normal, or a relative reduction in GLS of at least 15%. And we have to confirm these numbers in 3 weeks. Ejection fraction by echocardiography has shown to be a strong predictor of outcomes in the general population. It's very accurate, it's available, and it's very suitable for serial evaluations. But we know that has low sensitivity to detect small changes in ejection fraction. This is a study they did in breast cancer patients where they look at different ways we measure ejection fraction by echo, and they saw that when we use the 2D biplane method, the variability is very close to 10%, which is the criteria we use for cancer treatment-related cardiac dysfunction. So it's not very helpful. It's not going to be a great parameter to detect early changes. 3D ejection fraction by echo has less variability, and actually the American Society of Echocardiography recommends that this should be the method we follow these patients because it can detect cardiotoxicity much earlier than 2D EF. Now let's look at a strain. So for those not familiar with a strain, this is a parameter of myocardial deformation. The normal value is about -18. The more negative, the better. There are 3 different forms of a strain. The one that we normally look in clinical practice is global longitudinal strain because it's more reproducible and basically looks at the shortening of the left ventricle during systole. That's why it's a negative number. It has many clinical applications, and one of them is assessment of cardiotoxicity. But as anything that we measure, it has some sources of variability. So then the key is what of all these tools we have to measure cardiac function has the less variability, so we can monitor patients more precisely, right? And that way we can say the one that has the less variability is probably the one that is gonna be more helpful for us, so we can distinguish what is variability from true pathologic change versus variability due to technique variability. Okay, so in this study, they look at temporal variability of different parameters, ejection fraction by echo, 2D and 3D, strain by echo and MRI, and ejection fraction by MRI in healthy participants, patients with breast cancer who had not developed cardiac dysfunction in green, and then patients with breast cancer who had developed cardiac dysfunction. And you can see how there is a very nice overlap between the healthy participants and those cancer patients without cardiac dysfunction. And then when you look at the ones that have developed cardiac dysfunction, the less overlap was seen for 3D ejection fraction by echo, strain by echo, and ejection fraction by cardiac MRI. There was some overlap here for 2D ejection fraction. They also looked at the intra and inter-observer variability in this population. And you can see here how a strain has the least intra and inter-observer variability, very comparable with cardiac MRI. And I misspoke, the least variability is with cardiac MRI, but a strain has very close variability to cardiac MRI, followed by 3D ejection fraction by echo. So we've seen that it's an accurate, reproducible number, but we also know that it's a very good tool for early prediction of cardiac dysfunction. When we add a strain to clinical variables and ejection fraction, we increase the predicted value for further reduction in ejection fraction later on in the course of their disease significantly, as you can see here in the dark orange, much more than when you use any other echocardiography parameters. Now, so it's accurate, we can detect early LV dysfunction, but do we really change management? Do we do anything with this abnormal GLS? There are some retrospective, or I should say non-randomized studies where patients that had an abnormal strain during cancer therapy were put on beta blockers or not, depending on the criteria of the treating physician. And they saw that those patients who were put on beta blockers had an improvement in ejection fraction when they were treated with anthracyclines, trastuzumab, or both agents. However, those patients who were not put on beta blockers had no significant improvement in their ejection fraction. So until this point, there was a consensus that probably we should consider beta blockers in these patients who have an abnormal GLS. But very recently, we had the results of the first randomized controlled trial looking into this. Does a GLS-guided therapy improve outcomes in high-risk cancer patients? And they included patients treated with anthracyclines who had other risk factors to develop cardiotoxicity, who have a normal ejection fraction, no previous cardiac disease, and that had not been using beta blockers or ACE inhibitors before. So they randomized them into two different arms, an ejection fraction guided arm where they would start beta blockers and ACE inhibitors if they develop significant ejection fraction changes based on those criteria, or a GLS arm where they started these medications if they saw a relative change in GLS of at least 12%. And they were trying to titrate these medications to maximum tolerated doses and to continue therapy with trastuzumab. And what they saw is that in the GLS arm, the rates of cardiac-related treatment, cancer-related treatment, cardiac dysfunction was much less, 5.8%, compared to those patients in the ejection fraction guided arm, 13.7%, and this was significant. And they saw that at the end of follow-up, the changes in ejection fraction in this EF arm was more significant than the changes in ejection fraction in the GLS arm. Now, if this translates into better outcomes and less heart failure later on is still not known. The follow-up for this particular study so far is only 1 year, but hopefully we have more data in the future. But I think it's safe to say that if we start these patients based on a GLS strategy on cardioprotective medications, and we are able to stabilize their LV function, potentially we can make them more successful doing cancer treatment, and potentially we can improve outcomes in these patients. So we tend to do that. Now, what do we do when the patients develop overt LV dysfunction and heart failure symptoms? What do we do with their cancer treatment? So the decision to continue or not cancer treatment in these patients is quite complex. The American Society of Clinical Oncology stated that they cannot make any recommendations, and we have to take a patient-to-patient approach. The decision needs to be made by the oncologist in close collaboration with the cardiologist, and they have to balance the risk and benefits of each approach. So in the oncology side, the discussion is gonna involve what is the nature and the severity of the cancer. What happens if we stop this chemotherapy? Is there any other alternative non-cardiotoxic treatments with similar efficacy? And what is the purpose of the treatment? Are we trying to cure the cancer and improve survival, or are we trying to palliate and improve quality of life? And then in the cardiology side, the decision is going to depend on the severity of the LV dysfunction. How bad is ejection fraction? How well or not compensated is your patient? How good are they tolerating heart failure treatment? And don't forget that we should not assume that the LV dysfunction is related to chemotherapy. We have to do some work to make sure there is no other underlying etiology that we need to treat. What we know is that the sooner we start heart failure therapies in these patients, the better they are gonna do. And in this study, they looked at different patients that develop cardiotoxicity related with breast cancer therapy, and they saw that when you start therapy within 1 to 2 months of the recognition of the LV dysfunction, most of these patients will improve ejection fraction. Very interestingly, they saw that if they don't start heart failure therapies within 6 months, none of these patients recover ejection fraction. So we have to start early. Not surprisingly, these patients who didn't respond or who responded partially had the worst outcomes and the most rates of cardiac events. And then what they looked at, what are the variables that are gonna predict LV function recovery? The only independent predictors of that were the time to heart failure treatment, as well as symptoms. So the less symptomatic the patient is, the more likely they are gonna recover ejection fraction, which makes totally sense. They probably have less myocardial injury. Right, so this also emphasizes the importance of very close monitoring, so we can catch patients when they are asymptomatic or minimally symptomatic, so we can stop the process and they don't continue to deteriorate LV dysfunction to a heart failure symptoms that becomes then irreversible. For anthracyclines, there is not very robust data on what to do when they decrease ejection fraction. By the consensus is that we can allow patients to go as low as 40% ejection fraction as long as they are asymptomatic and in the right therapy with heart failure medications. And then we'll have to follow them very closely. There is no given protocol for these patients. We all see them frequently in clinic with physical exams. Probably we get the cardiomarkers, we get more frequent echocardiograms, but there is no established protocol that is recommended on how to monitor these patients who have already developed cardiotoxicity. Now, for HER2 therapies, we have more data. This is the SCHOLAR trial, which is a small trial, single arm, where they looked at patients who have an ejection fraction of 40 to 54%, who have no heart failure symptoms, and that were on ACE inhibitors and beta blockers. And what they saw is that when you put them in the right therapy, most of the patients are able to complete their planned treatment with trastuzumab. This is this red line here. This is the goal, completing all the cycles. 90% of the patients, through very small study, but 90% of the patients were able to complete the treatment. They also saw that at the end of follow-up, the ejection fraction in these patients was actually not significantly lower, and if something was higher when it started in the heart failure treatments. And similarly, we saw these results with the SAFE-HERT Trial. So the SAFE-HERT Trial also included breast cancer patients on trastuzumab. They tried to include real-world patients, and you can see that with a high diversity, race, and ethnically diverse population, half of those patients were Black women. They were not low-risk patients. Most of them had a significant amount of cardiovascular risk factors. They had received, most of them, anthracyclines before. And they saw, again, that most of the patients are able to complete their therapy with no events. And then when they look at the ejection fraction, when they started the trial, again, between 40 and 50%, there was no significant difference at the end of the trastuzumab therapy or at the end of follow-up about 6 months. And the only 2 patients that have to discontinue the therapy because of cardiac events or significant decline in ejection fraction, once you stop the trastuzumab, had an improvement in the ejection fraction on heart failure therapy. So it's difficult to know with these limited small studies and single arm if the added risk of cardiac toxicity by continuing trastuzumab in patients who have mildly depressed ejection fraction actually offsets the potential benefit in cancer survival. But as we said before, if we are able to make the disease stable, put patients on the right therapy and they remain asymptomatic, potentially we can avoid further decline in ejection fraction and overt heart failure symptoms. And when we know from oncology studies that it's important these patients complete the 12 months of HER2 therapy, there is a significant survival benefit as opposed to, for example, only 6 months of the HER2 inhibitors. So as a way to summarize what we do for patients with LV dysfunction related with cancer therapy, this is a classification that was put out by the Royal Brompton Hospital in England and is recommended by the European Society Cardiology guidelines. And basically here you have in your left early cardiotoxicity, either by cardiac markers or strain or both. So they recommend you at least consider starting these patients on cardioprotective therapy, and then we should continue cancer treatment without modification with very close monitoring, wherever that means, but very close physical exams, probably cardiomarkers, and as well as echocardiograms. And then here in your right, you have those patients who have overt cardiotoxicity because they develop symptoms of heart failure or because they have reduction in their ejection fraction. As long as they are asymptomatic, it is still okay to continue oncology treatment unless the ejection fraction is severely reduced. But we need to balance the risk and benefits of continue the cardiotoxic therapy in the way that we mentioned before in collaboration with the oncologist. They only recommend to interrupt cancer therapy if the patients develop symptoms of heart failure. And then at that point, we should pause, start the patients in the right therapies, compensate them, see what the ejection fraction does, and then make the decision if we have to modify the cancer treatment or we can continue with close monitoring. So to conclude, we saw that there is a growing population of cancer patients thanks to the amazing development of new cancer therapies in the last 20 years. And these patients have an increased risk of heart failure and cardiovascular events. Our goal is balancing minimal cardiac toxicity while not interfering with cancer therapy. It's important that we monitor these patients frequently because this will help to limit the impact of cancer therapy in the heart, as we will be able to prevent further damage and LV dysfunction and eventually overt heart failure. Cardiac imaging, and especially a strain echocardiography, is key in the early detection of cardiotoxicity and offers this window of opportunity to start cardioprotective therapy in early stages of disease. And cancer treatment should be continued in patients with mild or subclinical cardiac dysfunction, as long as they are closely monitored and on adequate heart failure therapies. And with this, I already told you everything I wanted to tell you today. I'm happy to take questions, and I hope you found this helpful or at least interesting.
Thank you so much, Marta. That was such a wonderful overview and covering all the data very nicely and succinctly. There is a number of questions from the audience here, so I'll go through this in order. The first one is from Andrew Perry. He is asking, he says, I recall reading about anthracycline use in pediatric patients and how the risk for cardiotoxicity persists throughout their life. Could you comment on that in contrast to data you showed where the risk of events is primarily within the first year of therapy?
Yeah, so that is true. There is an increased risk in childhood cancer survivors that persist throughout their life. And actually, if you look at the pediatric guidelines, they recommend to continue following those patients for years, for their whole life, depending on how much anthracycline and radiation and other risk factors you do it more frequently or not. So one of the theories is what I mentioned about this mesenchymal and progenital cell population that may be affected, and probably children are more susceptible as their heart is growing, right? And maybe the anthracyclines are more cardiotoxic in that sense. But we also know that these patients, either because of their previous cancer or because of their previous therapies, they also have more cardiovascular risk factors. They develop metabolic syndrome more often. They many times are sedentary. They may be obese. They develop diabetes, hypertension. So I think it's a different patient population than the adult cancer population, and that's probably why we maybe should be more aggressive monitoring those patients.
Yeah, and just adding to, I think one of the limitations is many of these studies look only to 1 year. They don't have long-term follow-up. So there's emerging data from, we looked at this in the Kaiser data set recently, showing that long-term in these adult breast cancer survivors, it turns out that their absolute risk for HFpEF long-term is much higher, but the relative risk for HFrEF is higher. And a large part of it is because it's not something that's clearly studied. There's a next question here. Does early detection of troponin or BNP correlate with strain abnormality? And I think along the same lines, does the early detection of elevations in these cardiac biomarkers translate to downstream cardiovascular events?
Yeah, exactly. So the studies looked more at LV dysfunction by ejection fraction. I don't know right now if I saw any study where they look specifically at changes in biomarkers and GLS, but I would say that probably there is some correlation. And the fact that in the study that I show where they were able to predict more robustly further LV dysfunction with the abnormality of both biomarkers and GLS makes me think that probably there is some correlation there.
That's great. And that looks like there's a lot of questions here about SGLT2 inhibitors from Alex Taylor, Eugene Yang, Doug Leedy, and Christy. So essentially, I guess the question is there any data for the use of SGLT2 inhibitors or Entresto in this population?
For SGLT2 inhibitors, there is not data yet. I'm sure there will be because it's a very hot topic. There are studies actually, and I believe it's called the PRADA-2, that is looking at Entresto in breast cancer patients to see if actually that can confer some primary prevention in patients that are going to be subject to anthracyclines because of their breast cancer. But I don't think there is data yet released from that study. I think it's still ongoing.
Yeah, PRADA-2 is still accruing. For the SGLT2 inhibitors, there are some smaller studies which are funded by the pharmaceutical companies. I know Duke is doing one with a very similar setup to PRADA-2, looking specifically at the use of SGLT2 inhibitors in this population. Another question, does CRP have any role in the prediction of cardiotoxicity?
Yeah, in one of the studies that I showed, and I'd be happy if you tell me who that person is to share that with that person. They look at CRP and they didn't see any correlation between abnormalities in CRP and LV dysfunction later on. And that's the only study that I've seen that I can recall where they specifically look at CRP.
Great. And here's a practical question. So when you see these patients in clinic and they have a reduction in strain, but they have preserved EF and they're asymptomatic without clinical heart failure, how would you treat them?
Right. So the first thing that I do, I always look at the echocardiograms, look at all the studies they've had and confirm that the number is real, and I believe the number. We are supposed to recheck that number again in 3 weeks to make sure it's real or not. If I believe it, as we said before, if I have a reason to start the beta blocker, I will start the beta blocker. If I don't have a reason and I confirm in 3 weeks that they are still depressed, that the GLS is still abnormal, I start the beta blocker.
Yeah, no, I think my approach is also very similar. It's a very difficult question. There's not clear guidance for it. Here's a question from Karen Redding. You showed guidelines stating that cancer treatment should be interrupted for symptomatic HFpEF and HFrEF. How frequently are breast cancer patients showing symptomatic heart failure versus subclinical dysfunction? Is it different in older versus younger women?
I don't know about that answer. I think most of the patients, at least that I've seen in clinic, they either present with LV dysfunction that are asymptomatic, or they present with overt HFrEF. I haven't seen that much HFpEF in my practice. What I've seen sometimes is patients that have already HFpEF and they start chemotherapy. But just HFpEF that happens to develop in chemotherapy, I haven't seen that often. I don't know if Richard has more experience with that, but it has not been my experience.
Yeah, I mean, I think it'll be more in the patients typically with the traditional HFpEF risk factors, the older patients with significant multimorbidity, as well as, risk for inflammation. I think those are slightly different populations. Great. And then it looks like Fareed sent a link for animal studies and SGLT2 inhibitors and protection against doxorubicin here. I think those are all the questions from the audience. I do have one question for you, Marta. So, traditionally, a lot of this treatment really surrounded the use of anthracyclines and trastuzumab, and we know these are cardiotoxic. In the field, there's some movement away from this. For example, now in triple-negative breast cancer, they're moving towards the use of immunotherapy as first-line therapy, and the general thought is there's going to be much less use of anthracyclines. How do you think this is going to impact our role in terms of surveillance and managing these patients?
Yeah, well, the first thing that we have to do as we are moving to more immunotherapy is gather more data on how we monitor these patients. Like we have many patients on pembrolizumab, for example, who may develop cardiac dysfunction or even HFpEF, as we were mentioning before, and we don't even know what to do with them. We try to discontinue the immunotherapy and then we follow the best we can, but we don't really have good data on what to do with that. I think that there is a very high probability that as we move away from anthracycline, the way we monitor these patients is going to change significantly. But I don't think we have data to say we should be monitoring these patients with echocardiograms regularly, as we do, for example, with the HER2 therapy patients.
Great. So it's always wonderful working with you, Marta, and that was again such an amazing talk. I want to thank everyone for attending this, and thank you so much, Marta.
Thank you,
everyone.
Thank you, everybody.